The story of AMAX4 is really the story of Max McKenzie. Max had a history of asthma and a nut allergy. Unfortunately, after unknowingly consuming a product with nuts, Max developed anaphylaxis. He was treated with usual therapy. However, his providers failed to recognize the severity of his illness and his failure to respond to usual therapy. The tragedy of Max's death led Dr. Ben McKenzie, Max's father, to develop what's now known as the AMAX4 algorithm. And today you're going to hear my co-host Will Berry sit down with Bruce Hoffman to break it down. Bruce is a critical care transport nurse, paramedic, and educator. If you ever have the chance to meet Bruce in person, it is truly a treat. He is one of the most friendly and kind personalities I have had the pleasure of knowing. He teaches at American International College, works critical care transport for Bay State Health, and is a senior educator with FlightBridge Ed. Will caught up with him right after his presentation at the FastCan conference. And what you're about to hear matters beyond just learning a new algorithm. The standard approach says intramuscular epi for anaphylaxis, but Bruce is going to explain why that a patient with both asthma and anaphylaxis needs more aggressive care, and why you have exactly 4 minutes from unconsciousness to irreversible brain injury to get it right. This isn't a teachable moment. It's not time for multiple intubation attempts. It's not time to second guess yourself. It's time for aggressive, decisive action by the most experienced provider on scene. One attempt at intubation, and if unsuccessful, immediate front of neck airway. That kind of confidence, the ability to recognize when standard protocols will fail your patient, to override your impulse to try the book answer one more time, to move decisively to the next intervention without hesitation. That's what these patients need. If you want help developing that level of operational confidence, we developed a community for you. Head to emspodcast.com to get more information on the Paramedic Confidence Builder. In the Paramedic Confidence Builder course, we teach the operational skills your school didn't. Decision-making frameworks, stress management, scene leadership, and deliberate practice methods that turn anxiety into competence. All right, here's Will Berry with Bruce Hoffman on AMAX4.
Hear you on 8. You on 8. Okay, you're clear. Stand by for your base.
All right, well, again, for Loud and Clear, we're here at FastCan with Bruce Hoffman, who just presented on AMAX4. So, Bruce, a little background. AMAX4 is short for something which we'll get to, but it was born out of an incredibly tragic event. It was the cardiac arrest and subsequent death of a teenage boy who had known anaphylaxis and asthma and had a precipitous deterioration in his status.
Yeah.
And that led to the advent of this treatment modality. So can you walk us through what is AMAX4?
Yeah, absolutely. So you're exactly right. The algorithm was born out of tragedy. And Dr. Ben McKenzie wanted to simplify the approach and the treatment for patients that have underlying reactive airway disease and those patients that are experiencing anaphylaxis. Those two diseases, when combined or concomitant, are lethal and really need very aggressive treatment and intervention very early. And so, the story of him, being allergic to nuts, ingesting, something that had nuts in it, and I emphasize the point that when they called 911, he was alert. And so he was able to talk to the paramedics. He was able to tell them what was going on. And the traditional treatment was sub-Q or intramuscular epinephrine,
Right.
Which eventually, allowed him to continue down this process. And instead of limiting the disease, they tried to treat it as best they could, but it was not enough. And so AMAX4 provides a very kind of regimented algorithmic approach to those patients. So like in Max's case, past medical history of asthma, along with having an anaphylactic reaction, he needs aggressive support right then and there. And so that's what AMAX4 was really developed for.
So on that point, I think that's a great place to pause for a second. If we're responding in a 911 capacity and we're getting to these patients very early in this disease process, those two history findings together should be very alarming to a pre-hospital provider. Would you agree?
Yeah, that should be a red flag for us in the pre-hospital environment, not only as like what might be going on, but that like it should signify early intervention. You look at like intramuscular epinephrine or subcutaneous epinephrine in a patient in extremis, that's going to take maybe 8 to 10 minutes, maybe 15 minutes to work. These patients, once they're rendered unconscious, 4 minutes until you have a secure airway. So it's really about recognition, but then also early intervention, early and aggressive intervention.
Yeah, and what is the intervention algorithm?
Absolutely. So AMAX4, the first A stands for adrenaline or epinephrine. The second stands for muscle relaxant. So that would be, kind of paralyzing and getting, the patient in a place where we can secure their airway definitively. The second A is for airway. And then the X stands for extreme therapy. So everything else that we're going to throw at these patients in a very extreme or aggressive manner. And then the 4 says you basically have 4 minutes from the time that patient is rendered unconscious to securing a definitive airway before you have brain death. And I would argue even before that, right? The hypoxic injury starts likely well before that, depending on the patient's underlying condition and their underlying history of reactive airway disease.
Right. We could be encountering this patient. We could be arriving on scene when they're already satting, in the low 80s or whatever.
Yeah. So, I mean, think about it. Saturations of 60 to 70 are not uncommon in the asthmatic or reactive airway disease patient. Now you throw on an anaphylactic or immune reaction on top of it. That patient needs aggressive intervention ASAP.
So speaking to that aggressive intervention, the AMAX4 algorithm is very aggressive with airway. Talk me through the primary approach to that and why so quickly are we leaning towards a front of neck surgical airway?
Yeah, I think oftentimes we treat sometimes intubation as a high risk procedure, which it is. And there are certain cases where it's appropriate to have, I think, teachable moments where you can let somebody, manipulate the airway and try to secure a definitive airway. These patients are going into the airway scenario already in a decompensated state. It's not really an appropriate or teachable moment. It's really a time for aggressive 2-person bag valve masking. You can use BVM with an LMA with end tidal as a bridge to endotracheal intubation, but it really should be aggressive, good BLS airway management first with definitive airway management. And I think we go after that through the process of endotracheal intubation. And then if you've tried one shot, I think the approach is to say they need definitive airway. It's not a time to really think about changing our approach or changing the equipment. It's really that person needs an airway because they're hypoxic and they're undergoing likely irreversible brain death. So getting into that airway is essential.
Yeah. And so you advocate in the presentation for one attempt by a very experienced, the most experienced provider on scene. And if you're unsuccessful, front of neck airway, correct?
Absolutely. Exactly. So one attempt for endotracheal intubation, and then you move right, maybe put some padding behind the shoulders, get the head back into position and do front of neck airway.
Yes.
So it's not multiple attempts at endotracheal intubation. It's one attempt by the most experienced provider. Hopefully the staff in the room are following a checklist. Medications are already drawn up. Hopefully this scenario has been simulated before, so it's practiced, so that when that person does do the initial intubation, they're successful. But if not, it's not a time to redo and rethink. It's to move immediately to the next intervention, which is front of neck airway.
Yeah. to back up a second, so if we play one of these scenarios out, and this happened in Max's case where he delivered his own intramuscular EpiPen,
Yeah.
and then, you know, many of our treatment algorithms are attempt more intramuscular epi, which I think it's okay for pre-hospital providers to do that, but we should expect that to probably not be successful. Why is that?
Yeah, exactly. So I think these patients are already in extremis. They're undergoing an exaggerated immune response. So there's a host of chemical issues that are happening there, and that's happening systemically throughout the entire body. So like I think the early recognition piece is imperative. And I think unlike some of the other traditional algorithms that we follow for treatments, this is not a time to kind of like walk down like further assessment. It's really all about intervention. And that's what the AMAX4 is, right? You think about IV epinephrine up front, muscle relaxant, followed by subsequent endotracheal intubation or front and neck airway, right to extreme interventions. So there's really not a lot of time for aggressive assessment. So I think the patients that are undergoing anaphylaxis are already in an exaggerated chemical response. Their body is responding to whatever allergen and pathogen, and it's exacerbated by the fact that they have underlying reactive airway disease already. So I think, you know, each of those by themselves in kind of independent silos, right? Asthma, yes, we can treat that and we can be aggressive about it. And sometimes we have a little bit of flex or play there. And on the anaphylaxis side, same thing. But you put these two together, it's not a 1 + 1 =
Right.
2. It's a 1 + 1 = 4.
Right. And then what would be a recommended aggressive way to administer epinephrine to these patients if we're assuming that our intramuscular is not going to be successful?
Yeah, absolutely. So I think you move right to IV epinephrine. So try to secure IV or even IO access if you can't get IV access. And then immediately 1 mic per kilo of epinephrine right out of the gate. So if Max was, I'm just going to say 50 kilos, it would be 50 mics of IV epi. And you can give that about every 10 to 15 seconds up to every like 3 to 5 or even 10 minutes, depending on their response.
Wow.
I think, you know, Dr. Weingart will talk about like if you have a 1 to 10,000 like Bristajet, you could literally just give a 0.5 ml of, you know, what we call like cardiac epinephrine, but that's essentially 50 mics. And just give that like every basically, you know, 10 to 15 seconds until you get that patient under control.
Wow. Some pre-hospital providers are able to provide muscle relaxants, some are not. Can you speak a little bit to why that is important?
Yeah, exactly. So I think undergoing endotracheal intubation without chemical paralysis in a patient that still has an intact airway, there's other issues that you're going to introduce into the scenario. You already have 2 major issues going on, so we don't want to introduce anything additional. So I think the idea is to get them fully muscularly relaxed so that you not only prevent kind of all of these other things from happening, but that you're also enabling success on the airway, which is coming subsequent to the administration of that.
And then finally, if you will you speak to a little bit of, you know, this AMAX4 algorithm is for the immediate aggressive treatment of these patients to save their life. Yeah. But they are very sick. Can you speak a little bit to some of the care they may receive in the hospital setting and where some of that care may be going?
Yeah, absolutely. So without a doubt, this person is likely headed for a hospital stay at a minimum, probably for 24 hours, right? I think, as I talked about before, like these independent silos of asthma and anaphylaxis, very easy to treat on their own, but it's really the combination of the two that's going to buy them really sustained issues down the road. And I think that's why the AMAX4 algorithm calls for so much immediate therapy. But I think about, you know, if you have a 10 or 15-minute response time, what's going to happen in the hospital? So hopefully they continue down the AMAX4 algorithm. And that's kind of what that X letter stands for, is like the extreme or aggressive measures that they might do outside of the pre-hospital environment, meaning inside the hospital. So maybe like continuous albuterol, continuous anticholinergics like ipratropium, which you typically don't do. You typically give up to a certain amount of milligrams, and then, you know, you're kind of done with that. but maybe sustaining like the sympathomimetic side of that. You can certainly think about steroids and some of the other like treatments, right? Like magnesium and some of this other stuff that we use to treat like asthma. But it really needs to be an approach of we're taking both of these into consideration. So, bronchodilation, whether it's through anticholinergism or through sympathomimeticism, I think about extreme ventilation. So maybe slower rates, extended IDE times for these patients, maybe larger volumes, 8 to 10 mLs per kilo, allowing for that patient to fully exhale. And then maybe thinking about some permissive hypercapnia, right? Maybe not going after that hypercapnia, thinking that we have to blow it all off, maybe just keep them at an extended IDE, allow them to, fully exhaust or exhale. I also think about, kind of like there's something called anaconda, which is like the use of anesthetic gases. So maybe this patient might go to the OR beforehand and be put on, inhaled anesthesia to try to bronchodilate them further so that they respond to that.
Wow.
And then obviously supporting their hemodynamic through vasopressor. So epinephrine obviously being key, norepi, you think about vasopressin, methylene blue, there's some data out about hydroxycobalamin, not sure where that's going.
Yeah.
But really being very aggressive. I think on the ventilation side, we're so used to seeing patients with high peak inspiratory pressures, but that really needs to be a consideration for us because these patients are going to have very high intrathoracic pressures because not only of their asthmatic process, but also because of the anaphylactic process.
Right.
So very difficult patients to manage. I think that's why, the AMAX4 algorithm is so succinct and so definitive in terms of what the interventions need to be.
Yeah. Well, thank you, Bruce. It was great chatting with you here at FastCan with the hustle and bustle of lunch happening in the background. But yeah, great talk. I love hearing you talk about it, and it's a great story. So thank you for bringing us the story.
Thanks so much. I appreciate the time.
Yeah.
That was Bruce Hoffman breaking down the AMAX4 algorithm. And if you caught what just happened here, Bruce didn't just teach you how to manage anaphylaxis with underlying reactive airway disease. He taught you a decision-making framework you can apply to your next shift to all your patients. Let me show you what I'm talking about and pull out the operational principles I just heard, because this isn't just about AMAX4. This is about how confident clinicians think when seconds matter. Here's what you should do on Monday and take to your next shift. 1. Build your red flag combinations. Write down the pattern pairs in your protocols or in patient presentations that should trigger immediate escalation. Asthma plus anaphylaxis equals immediate aggressive care. What else can you think of that would trigger a similar change to your usual approach? 2. Pre-identify your time-critical scenarios. For each one, know your decision window and your one attempt rule. If you're going to move to surgical airway after one failed intubation attempt, decide that now, not when you're holding the bougie in your hand with a hypoxic patient in front of you. 3, train yourself to recognize decompensation. The moment your patient transitions from sick to actively dying is the moment your decision rules change. Practice naming that moment out loud. That's what separates protocol-dependent responders from principle-based clinicians. Protocols tell you what to do. Principles tell you when to do something different. And if you want to build this kind of operational confidence systematically, where you can recognize critical patterns, make high-stakes decisions under pressure, and lead your team through chaos, that's exactly what we teach in the Paramedic Confidence Builder. We don't teach you more medicine. You already know the medicine. We teach you the decision-making frameworks, stress management techniques, and leadership skills that turn clinical knowledge into confident execution. Head to emspodcast.com to learn more, book a discovery call, see if it's right for where you are in your career. One more thing. If this episode gave you something you can use, help us out. Share it with another medic who needs to hear it. Thanks for listening. I'm Ross Orpit. Stay loud, stay clear, because what you do matters.